Cek satu, satu. Cek satu. Assalamualaikum warahmatullahi wabarakatuh. Cek. Ini lumayan dok kalau ini ini kan saya ngomong di sini, keluarnya di sini dok. Assalamualaikum warahmatullahi wabarakatuh. Bagus, bagus ya, main ya. Oke. Nanti ini bisa fokus. Dapat bertanya.
Izin bertanya, tidak kedengaran. Oh iya, Assalamualaikum warahmatullahi wabarakatuh. Assalamualaikum warahmatullahi wabarakatuh. Wih, mantap. Bismillahirrahmanirrahim. Alhamdulillahirabbil alamin. Arrahmanirrahim. Maliki yaumiddin. Iyyaka na'budu wa iyyaka nasta'in. Ihdinas siratal mustaqim. Siratal ladzina an'amta 'alaihim ghairil maghdubi 'alaihim waladdallin.
Cek satu. Cek cek. Cek satu, satu. Cek cek. Cek satu. Cek satu. Cek satu. Cek cek.
Cek satu, cek, cek. Oh, cek, 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 cek. Cek, 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 cek.
cek cek. Hmm.
Ya, aku ngomong langsung keluar di sini. Ngomong keluar di sini juga. Ya, di rumah. Tes, 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 tes. Dari ruangan ini keluar langsung. Nah, enggak feedback suara. Enggak masalah ya. Oh, ini tak disconnect aja. Tes, 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 tes. And it is my great pleasure to introduce our esteemed speaker, Professor Dr. Ina Ismiati binti Sharifuddin. Professor Ina is a professor and a senior consultant in the Department of Anesthesiology at the Faculty of Medicine, University Malaya, Malaysia. She earned her medical degree from the Medical University of Dundee, Scotland, and holds dual master's degree in anesthesiology and medical education with distinction from University Malaya. She's undergone an advanced fellowship training in pediatric anesthesia at KK Women's and Children's Hospital in Singapore and specialized training in pediatric liver transplantation in China. Her areas of expertise include pediatric anesthesia, advanced airway management, patient bed management, and medical education. Prof. Ina has held numerous leadership roles, including president of the Malaysian College of Anesthesiologists, the Malaysian Society of Anesthesiologists, and the Malaysian Society of Pediatric Anesthesiologists. She also served as on the executive committee on the Asian Society of Pediatric Anesthesiologists. Internationally recognized, he was appointed by the World Federation of Societies of Anesthesiologists to help develop their inaugural leadership module. She's also a chief editor of the Malaysian Journal of Anesthesiology, actively contributing to the academic development of the field. Her work has earned multiple national and international awards, including the Ronald Harlan Innovation in Medical Education Award at the Rogayah Jafar Award for Innovation in Health Profession Education in 2024. She also holds 2 patents for innovation in anesthesia and critical care. Currently, Prof. Ina continues to lead initiatives in sustainable healthcare, education, and patient safety, and we're truly honored to have her share her insight with us today. Let's warm welcome Prof. Ina Ismianti binti Syarifudin. Prof, the screen is yours.
Good evening, ladies and gentlemen. Thank you for all joining us. Good evening, ladies and gentlemen. Thank you all for joining us for this special guest lecture. My name is Alvan, and I'm honored to be your host today. As we begin, let us take a moment to acknowledge Allah's blessing toward us, to be grateful for His guidance, strength, and compassion that we can gather here in the state of health. May He bless our time together today. This guest lecture has been organized to give us an insightful look into the advance in pediatric airway management, principles, device, and pitfall that is for our daily practice. We hope you'll find today's program enriching as we explore what goes into providing high-quality pediatric anesthesia care for our patients. Before we start, I would like to recognize some of our distinguished guests joining us today. We're truly grateful for their presence. Please welcome Professor Dr. Ina Ismiarti binti Sarifuddin from the Department of Anesthesiology, Faculty of Medicine, University of Malaya, Malaysia. Thank you for being in this wonderful meeting here. We are truly grateful for the knowledge and expertise you bring. I would also like to welcome our Head of Anesthesia Department, the Head of Anesthesia and Intensive Care Specialty Programs, and all honorable guests and my fellow anesthesia residents. To officially begin this event, it's my pleasure to invite Dr. Rudi Fitraldiono. To officially begin this event, it's my pleasure to invite Dr. Muhammad Akbar Siddiq, Specialist Anesthesia and Therapy Intensive, who will lead us for the main guest lecture session. The screen is yours. Thank you, Dr. Muhammad Akbar Siddiq, for that wonderful session. I'm sure it resonated deeply with everyone here. Our main Thank you, Prof. Ina, for sharing those valuable insights. It's clear that managing a pediatric airways require a comprehensive understanding, clear planning and preparation, effective execution, and commitment to excellence. I would like to thank our guest, Professor Dr. Ina Ismiarti binti Sarifuddin. We hope that today's guest lecture has given us valuable insight into the purpose of achieving excellence in pediatric anesthesia and improving patient care. Thank you once again to our teachers, staff member, and all for you for your contribution in making today such a rewarding experience. We look forward to seeing you again and have a great time ahead.
Tes 1 2 cek sound. Good afternoon, Dr. Kasturi Supermanain. Assalamualaikum, Prof. Ina.
Waalaikumsalam. Hello.
Hello.
So I've got also some of my student online who joining this lecture. If that's okay with you,
Yes,
Rudy.
thank you.
Thank you
It's
for the
honorable
opportunity.
for us to receive your lecture in our room.
Ah,
Uh,
can
there
you
are
hear?
our students, residents, anesthesiologist residents in Brawijaya University. Can we start, Prof, with guide our MC?
Okay, can. Yeah. Can you hear me well, Rudy? Dr. Rudy,
Yeah, Prof.
can you hear me well?
Yeah,
Okay, good.
yeah, well.
All right, thank you.
Okay. Assalamualaikum warahmatullahi wabarakatuh. Good evening, ladies and gentlemen. Thank you for all joining us for this special guest lecture. My name is Alvan, and I'm honored to be your host today. As we begin, let us take a moment to acknowledge Allah's blessing toward us, to be grateful for this guidance, strength, and compassion that we can gather here in a state of health. May Allah bless our time together today. This guest lecture has been organized to give us an insightful look into the advance in pediatric airway management, principles, defects, and pitfall. We hope you will find today's program enriching as we explore what goes into providing high-quality pediatric anesthesia care for our patients. Before we start, I would like to recognize some of our distinguished guests joining us today. We're truly grateful for their presence. Please welcome Professor Dr. Ina Ismiarti binti Sarifuddin from the Department of Anesthesiology, Faculty of Medicine, University of Malaya, Malaysia. Thank you for being this wonderful meeting here, Professor. We are truly grateful for the knowledge and expertise you bring. I would also like to welcome our Head of Anesthesia Department, the Head of Anesthesia and Intensive Care Specialty Program, all honorable guests, and my fellow anesthesia resident. To officially begin this event, it's my pleasure to invite uh, Dr. Akbar, who lead us for the main case lecture session. And our main guest session, the guest lecturer will deliver speech about the advance in pediatric airway management, principle, device, and pitfall. Professor Dr. Ina Ismiarti binti Sarifuddin, the screen is yours.
Okay, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi ta'ala wabarakatuh, and a very good afternoon. Let me share my screen, yeah. Hmm. Give me a few minutes. Okay. Let me put it in the presentation mode. Okay, can everyone see my slides?
It is loud and clear, Professor.
And the slides are clear. All right. Okay. Assalamualaikum again. Thank you, Alfan, for that kind introduction. And first of all, let me thank Dr. Rudy as the head of Department of Anesthesia Faculty in Head of Department of Anesthesia and in University Brawijaya for this kind invitation for me to share my experience in this topic. So today, I was made to understand most of you are pediatric trainee anesthesia, and also I have some of my trainee who are currently doing pediatric anesthesia posting with me. I also invited them to join this discussion. So without further ado, I'll talk about advances in pediatric airway management, principles, devices, and pitfalls. So just a little bit of introduction. This is where I work. It's University Malaya Medical Center, which is a hospital under University Malaya. And if you can, it is actually a 1,600 bedded hospital. It has a few tower, okay? It started with just a very small tower here, and then only one tower, and then it's now has become big to incorporate at least 4 or 5 towers. And pediatric anesthesia, pediatric OT is in this tower that my arrow shows. It's colorful compared to the rest. We have about we actually have 3 OTs there, specially used for pediatric surgical, but the rest of the cases, we do everything except cardiac. Cardiac probably very, very rare, but hardly. But the rest we do in our main building, which is situated in the around this area, I think, in the main building, which within this area. Okay, so so we cover almost all pediatric subspecialty that you can think of, from neuroanesthesia, ENT, neurology, and yeah, all the rest. All right, so at the end of this topic, as I've been given to deliver, I would hope that all of you would be able to understand the anatomical and physiological principles unique to the pediatric anesthesia, recognize the latest devices and techniques for securing the pediatric airway, identify common and critical pitfalls and how to avoid or manage them, and if you can apply at the end on your time the clinical reasoning for selecting the appropriate airway device and plan for various scenarios. All right. So how many of you have actually faced with difficult airway in children? Many? Right. So we are so afraid of difficult airway in children, but in actual, if you look at this study done by Jagannathan et al., he looked at, I think, about 11,000 patients. And sorry, 77,000 patients. That's a huge number. And he found out that the difficult airway is only in 459 patients, which they actually had the problem managing the airway. And this is only 0.6% of all the total pediatric patients that they saw. So just to clear your mind, pediatric difficult airway is not many, but I think because this is in a very selected people, the experience matters. All right. So in another, that is in US, and if you look at the NetForce study, which is done in the UK, they look at the major complication of airway management in the UK, results of the 4th National Audit Project of the Royal College of Anaesthetists and Difficult Airway Society. They found that in that particular audit, there's only 10 events in children versus 184 events in adults. So the event is really low. And out of that 10 events, 8 cases were during anesthesia, and 4 was difficult intubation. And during anesthesia, 1 difficult intubation in ICU and 1 in OT. And the rest, and all patients were anesthetized in the presence of consultants. So again, as you compare 10 to 184, the ratio is very small. Only 10% of what of adult is facing, not even 10%, okay, half, 0.5%. So it does correlate with the American findings. And out of that 10 people, as I showed you, the four that they identified 4 independent risk factors that are associated with the increased risk of complication, in which if you have more than 2 tracheal intubation attempts, you are more likely to fail the third one if you don't do anything different. And then in patient that weight less than 10 kilo, in patient who has a micronatia, and in patient who has more than 3 direct laryngoscopy attempts before you attempt indirect technique. So this paper, NET4 study, was an old study. So you can imagine this was in early 2011, 2012, I think. So now indirect technique video endoscopy has been, we can get them rather easily in many centers. But I'm not sure what is the situation in all the rest of the hospital in Indonesia. But I was told by Dr. Rudy that video endoscope is something that you have in Brawijaya Hospital. So this is another, I'm just going to talk about incidents at the moment, all right? And this is another multi-center study that looks into 1,018 children in 13 pediatric centers, also in UK. And they found that tracheal intubation failed in 19 patients out of this 1,018. So it's about 2%. And 204 children have at least one complication. And the complication can range from hypoxia, laryngospasm, and stuff like that. And this is a recent study done by our colleague in Europe, which was published in 2021. And this is a nectarine study. I'm sure, I hope you have heard about nectarine study. Nectarine study looks into the morbidity and mortality after anesthesia in early life. And they look into the neonate and children. You know, when there's speech, they just look at children, the whole children, but in nectarine, they also specifically look at neonate. So neonate and children audit of anesthesia practice in Europe. And they found that the incidence of a difficult tracheal intubation is higher in neonates and infants than older children. So hence for us, if we look at all that, patient who's less than 10 kilo, they're definitely infant and neonates. And then in this study also, it shows that difficult tracheal intubation occurs in neonate and infants, and the unexpected difficult intubation may occur more frequently in neonates and infants, again, neonates and infants. And when a conventional direct laryngoscopy is used in neonate and infants with difficult airway, the success rate of tracheal intubation for the first attempt is extremely low. So what can we conclude from all these incidents from different regions of the world? You look from the study from US, study from UK, and now study from Europe in 2021. They basically say, yeah, there is difficult intubation, difficult airway in children, but the incidence is low. And in that low number, the difficult airway is normally in children less than 10 kilo, which is neonate and infants. So you have to have a red flag. Whenever you're going to anesthetize this sort of patient, you must be thinking, okay, I'm going to prepare myself for difficult airway, all right? And then there is a way out of it. They have said the successful rate of tracheal intubation is for the first attempt is extremely low if you use conventional direct laryngoscope. So in other words, if you have red flag, this patient is going to be a difficult airway, important for you to be able, if you have the resources, and you have to try very hard at this modern era to have a video laryngoscope, because they said tracheal intubation with a conventional direct laryngoscopy is always low successful rate. All right, so now, before I further go ahead, I'm just gonna let you think in your mind of a patient that we have. This patient is not even a neonate, not an infant, but a toddler, slightly more than 10 kilo, but he has a syndrome that all of us know would have problem with airway. So this is Adi, 2 years old, diagnosed with Pierre Robin sequence. Okay, if you look at him, just from the front, let me lay the pointer. Okay, if you just look at him from the front, there's nothing much that you think is going to problem. Okay, so he's scheduled for palatoplasty. And if you look at the side, yeah, there will be, if you look closely, there will be a slightly micronatia, right? So I think if you don't really pay attention and be aware of purobine sequence and you are not prepared for difficult airway, you might have an issue. So just keep this in mind before, and I bring you back to this patient. This patient was due for palatoplasty in another tertiary center, but unfortunately he had an event in that center where they were unable to intubate him, and he desaturated badly and had developed vocal cord edema and had to be put into ICU. So the operation was cancelled, but he didn't. Finally, they managed to intubate after desaturating and whatnot. But he has to postpone the surgery, goes to ICU and recover from there. So then the parents were not very happy, so they request to be brought to our center. So now let's look to the question, could this have been prevented with better preoperative planning? So I think this is something we need to know. So to plan, we need to be able to identify who are the patient at risk of difficult airway. So we must know that difficult airway can be acquired either in patient with airway burns or trauma, patient with airway infection like this one with epiglottitis, airway tumors, or a patient with tonsillar hypertrophy that will occlude the airway. And then patient with subglottic stenosis, it can be a congenital or acquired. And in patient who has foreign body aspiration. This list is not exhaustive. You can name more, but these are a few acquired condition where you are the patient are at risk of difficult airway. Then we look into what are the congenital abnormalities. There's so many congenital abnormalities that we can think of that can have airway problem. And these are some of the patients that we had in our center with difficult airway. And if you look at this one, this is something I took from internet though. This is a patient with pure robine sequence, and you know, pure robine it improves with age. But again, if you remember RD, although he's now 2 years old, at the time we see him, but he still have a feature of difficult intubation. So some other example patient that are at risk, as we note, are small neonates, you know, the premature babies, and small for gestation age babies. Those who weigh about, range from less than 1 kilo to ranging to 2 kilos. So let's move to the principle of pediatric airway management. So when I want to talk about pediatric airway management, we have to know the anatomy and the physiology of pediatric airway. But first of all, we need to know when we talk about pediatric, it covers a wide range of patient and size, right? It can be, as I told you, ex-prem with a weight about 600 grams to a really obese patient who is probably 12 or 16 years old, or even in his 10 years old, who is just obese. And that's the challenge. In a day list, you can have the range of children in your list. So with different appearance. So you need to be able to have an open mind when you see the list in your operating theatre, and you'll be able to gauge and identify who are those at risk. So before that, we need to know why children, especially neonate, have problem, right? So if we were to compare the anatomy of children versus adult, first of all, they have a bigger head compared to adult. And then they have larger tongue, they have smaller mouth, they have higher larynx, they have anterior vocal cord, and their narrowest part of the airway is their cricoid ring. If you can see, the shape of the trachea is not cylindrical like what is in adult, but it's noted to be funnel shape. Though this has been debated whether they are actually just like an adult also, which some of the current debate is they are cylindrical in shape, but many cadaveric study still shows that it is funnel, means they have wider supraglottic and narrower towards infraglottic. And because their lumen is very small, if you compare children and adult, right? Adult 20 mm and in children 4 mm. So any edema, to whatever reason, due to multiple attempt or due to your RTI, their opening diameter will be smaller. All right. So when this happens, then you can create, if it's your RTI, you can, and then you can imagine with secretion and whatnot, it will make the obstruction worse. As compared as an adult, they have bigger room for you to move around. All right. And if you have multiple attempt more than 3 times and you create edema, so you will have patient who will have obstruction as well. And as you know, infant are nasal breather, so anything that cause obstruction of nasopharynx will compromise the ventilation. And they also have, as I mentioned, larger tongue. What are the implications? The implication is the airway will be easily obstructed during back mask ventilation. So you must be able to hold the airway appropriately. Or if you're in trouble to open it up, you need to use other gadget such as such as your oropharyngeal airway. And they also have floppy uvula. So the type of laryngoscope that you use is very important. And also the technique of lifting up the uvula should be used. And I've mentioned about the funnel trachea. You have to choose the correct ETT. And because of the nervous part is at the cricot ring, the size of ETT matter. All right. Then we go to the physiological part of it. They have short apnea time. This is the killer for us, right? Because they are difficult, and then they have short apnea time, and then they desaturate very fast. Hence, they desaturate very fast. And why do they have short apnea time? This is the physiology we need to know. And we know that they have higher basal metabolic rate. And adult has higher than that. And their closing capacity encroaches their functional residual capacity. So the moment as a neonate, you know, they can collapse their lung easily. So they have poor oxygen reserve. So this will lead to short apnea time. And they also have low lung compliance. So it just shows that you have double trouble, if you know what I mean. They have relatively difficult airway because they're small and all the other part that they're anterior and whatnot. But simultaneously, they have all this small capacity to reserve oxygen. So you need to be able, what I'm going to say is your first attempt is very valuable. You need to be prepared to ensure your first attempt or at least your second attempt is a good attempt so that you don't get into trouble. And planning is a big part of this. Okay, so when we talk about difficult airway, you have to understand this concept. I think this is a very important concept, that difficult back mask ventilation doesn't necessarily mean difficult supraglottic airway incision and doesn't mean difficult laryngoscopy and intubation. There will be chance where they actually overlap each other in CICV, but it's quite rare. So once you cannot back mask ventilate, you have to quickly then think, should I go to SGA? And FGA cannot sit in, you should quickly think that, you know, you only give yourself 2 attempts and then you have to then move on to difficult laryngoscopy. So you need to be able to move around this. And this is a very important concept that you have to understand. And in managing difficult airway, human factors are very important and cognitive factors is very important. Means if someone is already in that trouble, you need to call for help. You need to be able for someone to come and see what else can you do. Okay, that's why in any emergency, airway is important. Assistant is important, and in particular when it's a difficult airway, you have to be very specific to say, I need a senior help. Okay, I need a consultant help. If you're the trainee, I need a specialist help. And then sometimes you're too immersed in it. Even your senior nurse, sometimes they know better than you. They would give you some ideas. You have to listen because sometimes your cognitive are just over focused to I'm not able to ventilate this patient that you forgot you haven't moved around, which I'm going to bring you to a concept of vortex. And then before that, you need to understand the importance of new device and new techniques, which I'm gonna elaborate towards the end of in some part of this lecture. So I like to bring you to the thought of human factors. If you've read about Elaine Bromley. This is the family of Elaine Bromley, the husband uh, uh, who is a pilot. All right, his wife just went in for a simple a simple foot operation, ingrowing toenail. And in this situation, his wife died at the end because the anesthetist could not ventilate her. And it's not just one anesthetist, there were four anesthetists in it. And he was very surprised because he said, how can four anesthetists not able to ventilate my wife? And then he came out with, it's very different from aviation when everything is in a system, and the human error is very little. So in our day-to-day work, human factor is an important thing. So fixation in performing difficult tasks is a major problem. So we need to call for help so that we won't be fixated to a problem that we have when we cannot ventilate a patient. So a study demonstrated that students or trainees that is engaged in a challenging task underestimate the elapsed time by 40% when compared to an easy task. So when you're so immersed in a problem, you have this tunnel vision of your problem, you forgot that 1 minute has gone to 3 minutes, have gone to 15 minutes, and you've then actually had a patient who is in hypoxic event and will develop hypoxic ischemic encephalopathy and eventually arrest. So you need to have an algorithm to enhance your situational awareness and to facilitate decision making, so that people will remind you, okay, you failed this part, what are you going to do next? So this is an important part of the cognitive that we need to know. So here comes the thing that I call vortex. If you remember my slide early on where you have to move around, it's actually also demonstrated in a cognitive aid where they call vortex. All right. You can use any other cognitive aid, but I just want to illustrate how if you move around in this back mask ventilation, and you can't back mask ventilation, you go to back mask, you can't, you go to supraglottic, and then you goes to ETT. As long as you can move around, you're in the green zone, you're okay. But if you are in the darker blue and if you move around, you cannot get your airway, you will then slowly spiral down. So never get into this cone situation where you're spiraling down and you are in so deep, lubangnya terlampau dalam that you cannot go out, and at the end of the day, patient will die. So you need to be able to move around, and then if you can't, the next step after you have moved around and you still stuck in CICV, you then need to think about emergency surgical airway. All right. So far, okay? Is my pace too fast?
No, Professor.
Okay, yeah. All right. Okay. Let me hold on. Okay. All right. So when you want to have cognitive support, then you need to look into some difficult airway guideline. All right. For adult, you can choose to use whatever guideline you're familiar with in your local setting. But like in my center, we adhere to Difficult Airway Society guideline. And in children, this guideline is pretty old. I'm very sure it needs some new guideline. But at the moment, they haven't come up with anything new. And I'm not going to elaborate on this because it's quite tedious, but I would recommend you go back. One thing that they don't have in here is the use of video laryngoscope, which in adult they have actually looked into. So I think we are due to have a new one soon. So these are all the guideline which the Pediatric Anesthesia Association have come out in line with the Difficult Airway Society in UK. So yeah, so I think I'm not going to go through here. I think I would appreciate if you all would go back and look into it and compare it, understand it, discuss with your team on what is advised here. But I would like to look into all the different devices that we have now. So, when I talk to my trainee, I think one of the important um thing that we in children is be able to be confident in managing the airway. As long as you can get the airway, and then you can be rather rest assured the other things you can slow down, like getting the line, even the line, if you can't get because patient is fully dehydrated, there's some other, surgeon all can help you, but airway is actually our territory. So we need to know our airway well, and we need to know what are the senjata yang ada pada kita for us to use. So first of all, we need to be able to hold the airway properly. So in back mask ventilation, positioning the patient, holding the airway, keeping it open is very important. You see how this patient when you put a mask, you must choose a mask that would not compress the nose, and also a mask that you can cover the whole mouth altogether. So when you want to bag, you have to be able to open the mouth this way. If in any event you can't, then you have to think, my next step is to put in a oral pharyngeal airway. I try my best not to do a nasopharyngeal airway because children are normally nasal breathers, so I do not want to disturb them with that. All right. And then in positioning of patient is very important. I think for 8 years old, it's not a problem because it's like any other adult that we have, you put them on a headrest, and then you have to ensure that their external auditory meatus is actually aligned with their suprasternal notch, then you can actually see that this anterior neck space is wide open. Okay, but if it's in smaller children, is in an infant, you have to see, infant and neonate, they have bigger head. So depending on their head, you can use the headrest. Here we use donut, and we still need to make sure that the external auditory meatus is same level at the suprasternal notch, and we have to make sure that this is wide open. All right, and if you need, you have to put a shoulder roll behind it just to elevate this to put the patient in this position, because we don't want it to be like this where everybody is so close. When patient is like this, then you can see that the tongue, which is going to be big, is going to fall back. You will be having problem to, the head is flexed. You'll be having problem to just open up the airway. And in PIDS patient, they will desaturate very fast if you are not able to open up the airway. All right. And in neonate, their head is big. So sometimes we recommend they don't need the donut so much, but what you need is to put a shoulder roll under the shoulder, right? We can use towel, green towel, and put it under the shoulder like this. So this is also to open up the airway, all right? So when you have that view, you have positioned patient correctly. So when you put a laryngoscope, you will have a direct exit, and you can see this view nicely in a direct laryngoscopy. But if it's very anterior, despite positioning as what we have recommended, and you still can't see it, and you can't see this with your external laryngeal manipulation, then after 2 attempts, you need to go get your video laryngoscope, all right? Because if not, you're going to attempt more and you're going to cause trauma to the airway. So when you reach into that position, the reason I'm bringing up this slide is because people ask, in anticipate difficult airway, do you want to paralyze or you maintain spontaneous ventilation? So, saya mau nanya ya, what do you normally do? Any thoughts? Do you paralyze or do you just do spontaneous ventilation throughout? Any opinion?
Yeah, in paralyzed professor maybe.
Sorry? Alfan,
Uh,
what's the practice recommended to your trainee?
unparalyzed professor.
Right, great. So this study shows that they look into complication in the pediatric difficult intubation registry using propensity score matching, and they look into they have a retrospective analysis of neuromuscular blocking, drug use, and ventilation techniques on complication that occurs. And I don't know why I cannot move this slide. Okay. Wait. Hold on. My slide is not moving. Resume. Okay. All right. So, what they found is when they look into spontaneous ventilation, they found that it increases non-severe complications such as hypoxemia and laryngospasm. Why? Because when there are spontaneous ventilation, especially when you use gas induction, then at certain point they will have light anesthesia. And light anesthesia was found to be the likely cause of this complication in patient with spontaneous group, because when spontaneous group you will have light anesthesia, right, when you take away the mask. So they recommend that if in anticipated difficult airway, it's better to use neuromuscular blockade agent should be administered if airway reactivity occurs. If you try spontaneous and you find that they go into laryngospasm, just paralyze them. If not, you will have problem, and most of it will be associated with complete ventilation failure. So this is the picture of laryngospasm. So it occurs when your vocal cord from open like this become closed, occurs when airway manipulated at light plane. Okay, so now let's go to the second device. So choosing the mask, in back mask ventilation, I think the position of patient is important. The way you hold your mask, in the position is paramount. The way you hold it is important, and whether you're gonna mask ventilate spontaneous or with drugs. And then what I did not touch is the use of oropharyngeal and nasopharyngeal airway, but I think I will leave that to your discretion. But the next thing I'm going to talk about is the next one is the use of supraglottic airway device. So supraglottic airway device, if you see this one is the first prototype, okay, the classic LMA, and throughout the years they have evolved into second generation. And in my center and in Malaysia generally, many of us have moved to second generation, which is Supreme, iGel, Ambu. So may I know, in Brawijaya, what do you use? Anybody?
iGel professor.
Oh, you use a lot of iGel, is it?
Yeah, we have almost every Supreme LMA we have.
Oh, you have all. You've got Supreme, LMA, you've got Ambu,
Yeah, we got Ambu also.
but your main is iGel.
Yeah, a lot of iGel we use for LMA.
All right. Okay, so it doesn't matter. As long as you know, I think in you choosing what devices you want to use is up to one preference, but most importantly, you need to know the limitation, the advantage and the disadvantage of each device, which I'm not going to go into this so much because this is another different lecture altogether. So when we use second generation, um, they show, this is when they use the first generation, all right? What are the incidents of failed airway with laryngeal mask? So this study was published in 2013, about 12 years ago. And they showed that out of 11,000, near 12,000 pediatric anesthesia cases using LMAs, only 0.86%. So very low, okay? So it is, if you cannot mask back ventilate, then the ideal thing is next to move to your SGA, because the failure rate is quite low. And we also did a study in our center. Unfortunately, we did this in 2000. We published this in 2018. Our numbers slightly higher, 11.6% failure rate. I'm going to tell you why. We did it in patient that used a size 1.5 Supreme. This was a randomized control study. And our failure rate was slightly high because we found the cohort that has the failure was in patient who has weight between 5 to 6. Just for some reason. Just for our hypothesis were these children, in Asian, we have Chinese patient who has and in Asian patient, our TMD is slightly different from Caucasian. So a lot of, and we use AMBU. In this study we use Procil and LMA Supreme, and the failure that we found were patient using 4 of it is in Supreme, and 3 of it in 4 of it in Procil and 2 in Supreme. We felt that the device are more designed for Caucasian, and in this age group, and in this weight where the thyromental distance is pretty short, maybe is very not suitable. Hence, in my practice, if I have patient at this age, this weight, which is about 6 months to 7 months, I won't force it too much. If I've tried to use LMA 1 or twice, I fail, then I am more alert to say, okay, my third attempt might be a failure, so I might as well intubate them. Okay, so it just gives me a little bit of awareness that I might have a problem, because it's by our own experience. However, looking at if you are able to put in an LMA, if you want to intubate the patient, second generation LMA, you can then easily change it to intubate a patient via this. And we actually look into a small group of patients. This study we were meant to do in a bigger cohort of patients, but unfortunately, COVID came along and we did not manage to finish our study. But we look into patient who was 2 years old, and we insert AMBU, aura gain, and then we try to change intubation. We try to change the tube using this AMBU aura gain, and by using a scope to change the tube. And we look only at small cohort, about 16, if I'm not mistaken, 16 patients. And our overall success rate was 87, with intubation time from after getting a airway with the SGA, we need about 57 seconds, which is not too bad if you are in a difficult airway situation, because at any time we were able to ventilate the patient with the supraglottic airway device. And our successful first attempt was 81.3. Actually, this was a little bit a miscalculation, because we also said we only had a failure in 2 patients, and one of the patient is not because we could not put a tube, but we actually dislodged the tube when we tried to take out the LMA. So actually, the number that failed was only 1. But because we calculate the overall was from the point of intubating and removing the LMA, so one of the patient had a dislodged tube due to removing the LMA. So we wanted to demonstrate here, that intubating through an SGA for children is also an option. So then comes the latest device that is in the market, the role of video laryngoscope. And I think all of you had different experience, I think the rise of COVID has brought us to the role of video laryngoscope. More and more center has video laryngoscope. And the one that we use here are STOTS and GlideScope. And they have been very useful to us. So a lot of study has shown, this is rather old studies, but it just shows that the efficacy of video laryngoscope, GlideScope in children is very good. GlideScope improve clotic view. However, we need to be very aware, very mindful that improved clotic view doesn't mean improve insertion. You need to be able to know that you're actually looking and looking at an anterior vocal cord, and you need to bend your tube accordingly so that you can have a higher chance of successful rate of intubation. So we really love our GlideScope. I think this GlideScope has been very very berguna ya kepada kami semua. We've got so many difficult airway, and because most of the problem, I think they have anterior. This is a patient with Tricia Collins. This is patient with uh Pierre-Robin. This is a very small patient, I think about 600 grammer. I cannot remember. This is a patient with, all these other congenital abnormalities. And you can imagine trying to direct laryngoscope them will be difficult. But all of them have anterior airways. So using video laryngoscope that cater for anterior airways like like GlideScope and D-blade in CMAC is very useful. So that's why you need to be able to understand the use of your device, practice it in your normal patients. So when it comes to all this difficult airway, you know how it works and how it's function, and you're very familiar with it. So what else is new? It's not very new, but it's been used more frequently now is TRIVE in children, tranasal humidified rapid insufflation voluntary exchange in children, randomized where you use it. If you look at this picture, this was used in patients who go for vocal cord surgery, where you don't have to intubate them. But TRIVE also can be used in difficult airway if you anticipate, all right? And TRIVE prolong the safe apnea time in children, but has no effect to improve CO2 clearance. So what you can do is it gives you the chance to actually do different maneuvers, call for help, do different maneuvers if you are stuck in difficult intubation, because it gives you the oxygenation during that supposedly apnea time. However, in Malaysia, this is rather expensive. This whole set, the disposable. We have a lot of the machine because due to COVID, but where you ventilate them with this, but the consumable is quite expensive for us. It's about, if I'm not mistaken, it's about 500 to 600 ringgit. So to say that we use it, so we also don't use it so much, unless the patient would need to use it we need to carry it back to ICU. But so far, we only need to use it intra-op. So what we do, we use a nasal prong instead. So instead of using a drive, we put nasal prong. I know nasal prong doesn't have the humidification, but when patient is asleep, we can increase the nasal prong flow from 2 or 3 liter per minute. We can increase it to 15 minutes just to buy time for the apneic oxygenation. Okay, so you don't just have to use the gadget alone. You can then combine it, what we call a flexible intubation video endoscope. we can before I go to the combine, this is the flexible intubation video endoscope, which I think in children you rarely use it awake, but we can use it under sedation. But what more interestingly I like to bring upon is combining the techniques. Sometimes they are just too anterior. You cannot get through with just video laryngoscope. You then can combine the use of video laryngoscope and fiber or with your video endoscope. And you can then but you need two person actually, one person to video laryngoscope and one person to put the the flexible intubation video endoscope and railroad the tube inside. So I think in my experience, I've probably used twice in a very anterior pure robine patient. So it's a good technique to use. Okay. So last but not least, just give me 2 minutes, yeah. Okay. Last but not least, I'm going to bring you into the emergency surgical airway. I think this is a scary part, right? Where cannot intubate, cannot oxygenate, cannot ventilate, cannot back mask ventilation. You are now in that vortex down there, and you know you only got in neonate, you only got infant, you've only got less than 3 minutes to bail yourself out of this, all right? Previously, many years ago, they actually say do needle cricothyroidotomy, all right? And with needle cricothyroidotomy, these are the sets that they use. You have to have 16 gauge catheter, 3cc syringe, and 7.5 endotracheal tube adapter, and you connect them. So you pierce, and then you get you do a percutaneous, and then you try to ventilate, but you cannot use the back. You have to use modified way of ventilating. But you know this is very, very difficult. It's a very small hole. It's just to buy time before you get an ENT to come and do the tracheostomy. And even then, sometimes ENT will also struggle with this, especially in small baby. So much so, okay, the last time they think when you do the problem with needle cricothyroidotomy is complication perforation of the posterior tracheal wall. And at that point they said front of neck access, although it get 100% attempt success rate, but more significant posterior tracheal wall damage. So a lot of people in that time, we just learn how to do needle cricothyroidotomy. However, thank God I've never had to perform one. And of recent, this is the latest publication in Pitts Anesthesia, which is published in 2023. Okay, this is emergency front of neck access in infant, a pragmatic crossover randomized control trial comparing two approaches on simulated rabbit. They use rabbit, okay, but these are the same group of people who did nectarine study who said that neonate has actually higher problem of getting difficult airway, and they compare two different approach of simulated trial. So I'm just going to share with you the one that they think is the better one. And they compare a scalpel bougie tracheotomy, which they said SBT, versus rapid sequence tracheotomy, which I'm not going to quote here because this group of people suggest that we should be using scalpel bougie tracheotomy, which is not far different from our eFona in adult, except we don't really look into that cricothyroid membrane and all that because it's really, really, really difficult in these small children. So what they recommend, the pathway to do it is tracheal palpation and vertical midline skin. They need the same thing. They need scalpel. They need ETT, and they need Cook's Airway or Frova, 8 French Frova. Okay. And they recommend that you do the tracheal palpation, the laryngeal handshake also, and then you do a vertical midline skin incision of 2 to 3 centimeter from the cricoid in a caudal direction, followed by a layer by layer incision down to the external surface of the trachea. This longitudinal tracheal incision of 2 to 3 rings, you don't have to be so afraid to do that incision, because if you don't open it wide enough, you won't be able to see the trachea, and this will increase the time to get into the trachea. All right, so do a generous incision, and then once you see your trachea, you incise your trachea, you insert the 8 French flora through intubation catheter through the incision into the distal trachea, and then you railroad the 3 mm cuff tube into the tracheal tube, and then you take it out. But you need to have with you, I don't know what you call this, pemegang untuk open it up, all right? So that you can have a good access to the airway. So recently, we did this simulation in a workshop, but not in our center in Australia. I went to try this in Australia, and it is really good to have a simulation on how you can do this, because in this study also showed that, no, not in this study, in another adult study, they showed that you must have actually experienced twice how to do it every year, so that you keep up to the technique, because you never know when you have to do this. It's like something that, like malignant hyperthermia, you never know when you're going to get it, but if you get it, you have to know the steps. So it is recommended that everyone should be able to do this, especially if you are going to deal with children. All right, so I'm coming to a couple of last slide. If you remember the patient that I show you, Adi, earlier on. So because he already had a difficult airway, failed intubation in another center, we were very clear about what we wanted to do. We had a team with skilled anesthetists and assistant. We had our video laryngoscopy. We had a clear plan of what we're going to do. We had a briefing with all our teams, with the JA nurse, with the trainees and lecturers, we're going to do it, and what would happen, and also with the dental oromaxillofacial team of what is going to happen. So we had our video laryngoscopy, we had our supraglottic airway device suitable for the patient as a rescue if needed, the supraglottic airway device. And we also plan to use the SGA as a conduit for intubation if we need to. So at the end, with all our preparation, patient had uneventful video laryngoscopy intubation, which was fine, and everything went well. And the patient had a successful surgery, and the parents were really happy, and we were very relieved. So as a conclusion, take-home message, I have to say, children's airway is different from adults. You need to understand the anatomy and the physiological limitation of children when you want to intubate them or manage their airway. And then we need to train ourselves to recognize difficult airway. It's better to err on the side of over-recognizing rather than under-recognizing, because once you have recognized, then you will be able to have a good preparation. You've got to alert people that you need to be with you. So you have to have a backup plan. Go through, when you have this sort of problem, it's good to have team briefing and say what is everybody's role going to be. That's the human factor in this. And you have to have all your equipment ready to check and ready, so that if you have a plan A, plan B, plan C, everybody knows when are you going to move into that plan. And if you have practiced this either in simulation or in elective cases, then you would have it's easy to be transferable into an emergency. Last but not least, we need to have that cognitive assistant. It's sometimes very difficult to remember your difficult airway, but I know that the one provided by APA is quite difficult. I normally just use Difficult Airway Society DAS guideline, because adult and children, it's the same. You cannot airway back, must ventilate, you go to supraglottic. Cannot supraglottic, you go to intubation. And then when you cannot go intubation, then you need to do E for now. So it's pretty straightforward. You only have that much that you can play around. But what is most important, you know what equipment is available in your center, okay? Because there's no point me telling my center have all this, But at the end of the day, if your center doesn't have it, then you still cannot manage. So you need to now, today, what I think you need to do is go back to your center and see what you have, so that if you have difficult airway, you know how to optimize your equipment. And last but not least, you have to understand all this new equipment and train to use it. All right, for that, I think I would like to end. In Airway, it's all about planning. And if you fail to plan, you're planning to fail. With that, I thank you.
Yes, that was wonderful session, Professor Ina. It's my pleasure to invite our distinguished moderator, Dr. Muhammad Akbar Siddiq, Specialist Anesthesia Therapy Intensive, who will lead us to the discussion session. For the Dr. Akbar, the screen is yours.
Okay. Once again, I would like to thank Prof. Ina for the wonderful and wonderful presentation and comprehensive presentation. I'm sure many of us have gained valuable information and new perspective on pediatric airway management. We now move on to the discussion and the question and answer session. This is your opportunity to engage directly and ask your question to our expert speaker. If you have any question, you can ask directly using the mic, or you can write it first and then you can ask the question. Maybe any question to the live audience first, maybe.
And Dr. Akbar, can I say something? I feel if you think language is an issue, I have no issues. You can speak to me in your language and I will try to also understand it and reply accordingly with maybe some translation if I'm wrong from Dr. Akbar and Dr. Alfan. Yeah. Just I will try to answer as much as I could. And if I can't, I promise I will follow up. You can email me and I will follow up with more better explanation.
Okay, thank you, Prof. Ina. You can ask the question in Indonesian if you would like to. Okay. Boleh nanya dalam bahasa Indonesia.
Assalamualaikum dokter. Good afternoon.
Afternoon.
My name is Tejo. I am the resident program in Anesthesia Brawijaya University. I have one question about endotracheal tube, Professor. Can you explain different about endotracheal tube cuff compared to ETT cuff, the age group, especially in premature neonatus, which one is better? Thank you, Professor.
Okay. So okay, thank you to
Tejo.
the Tega, Tegu.
Tejo.
Tejo, thank you for that good question. Yeah, I did not elaborate further on the type. I did not touch too much on the type of endotracheal tube here. Okay, so if you, first of all, you still have to understand the anatomy, okay? There is two school of thought saying that trachea in children is cylindrical or actually ellipse, and versus the vocal cord, the trachea in children is funnel. The old school, we still say it's funnel, and I think many pediatric anesthetists still feel it is in a funnel shape. Okay, so when it is in that, you have to be very careful when choosing your endotracheal tube, right? Because if you're going to choose the endotracheal tube, if it is a cuff tube, then the cuff must be not too tight, generating the size must be smaller. The size of the tube will be smaller than the trachea, so that when you inflate your cuff tube, it won't cause pressure around your trachea. So what is the difference? Okay. Actually, there's a lot of company who has tried to imitate endotracheal tube with cuff, but the original one, oh my God, suddenly I just forgot the name. It is very the cuff is very Kimberly Clark. Kimberly Clark is the original cuff endotracheal tube. If you go and Google Kimberly Clark, but they have lost their patent a few years back. So now many companies have come out with their cuff tube, and they say it is like Kimberly Clark, but banyak yang bukan ya. Kimberly Clark tu, the tube, the cuff is not elongated, not like our adult tube. You know, because the length of vocal cord to trachea, can you imagine in neonate is very short. What is the length from vocal cord to your vocal cord trachea to the carina in adult? It's long, right? Because we anchor our tube at 20, so you can imagine it's about 15 centimeter, right? But in children, it's only like about 2 centimeter. If you pull too deep, push too deep in neonate or you can then go one lung ventilation. So the length is very short. So because of the length is very short, you cannot have a cuff tube that has a cuff tube like an adult. You have to have a cuff tube that is small, which is spherical. If you look at the Kimberly Clark one, it's spherical. So when it is small like that, it is low pressure cuff volume, all right, which is important, low pressure cuff, and it won't, and when you put pressure, the pressure wouldn't cause too much pressure along the trachea. So that's the best. But now with a lot of imitation, you just have to be very careful when you say, oh, I'm okay, I'm using a cuff tube. And the cuff tube is meant for children. Banyak juga saya jumpa di Malaysia kata cuff tube, tapi the volume, the volume is huge. It's not small like the Kimberly Clark. And when it's not small, it occupies a huge part of the place between vocal cord and trachea. And when the danger is when you extend and then the balloon will come up above the vocal cord, and that can cause a lot of irritation, a lot of trauma, and that's the part where we worry can cause trauma, and at the end of the day, you get stridor, edema and lead to stridor, all that. So now I come back to whether you want to use cuff tube or not. So in general, in my practice, some people might have different, that's why I said there's two school of thoughts, right? But in my practice, I don't use cuff tube in children less than 8 years old, because above 8 years old, they are normally practically like adult already, their airway. Because of this, their trachea is still funnel in shape. I do not know, I don't want them to have this trauma. But I do use them in a few situations. First, in case where it's a difficult airway, all the congenital abnormality, and this is a difficult airway. The last thing that you want is multiple attempt. Sudah masuk tapi leaking, kan? Then perlu tukar lagi. So you don't want to create that problem, right? So in that sort of patient, I would use cuff tube, but I would be very particular which cuff tube. I will only use Kimberly Clark, and anything that represents something that look like Kimberly Clark. Nothing. I'm very particular to look at the balloon, how they do it. And then in patient who are going to have thoracotomy or laparoscopic, not thoracotomy, thoracoscopic and laparoscopic, because you're gonna need there will be a deep push for pressure, and you need to ventilate with high pressure also. So you don't want your pressure to leak, because if you use uncuffed tube, you tend to leak a lot. Even if you choose a good cuff, a good non-cuff, you tend to leak. So we don't want to have problem in ventilating. So in this sort of patient, I would use cuff tube. Does that help?
Terima kasih dokter. Saya terima kasih.
Menjawab soalannya?
Terjauh dokter.
Okay, thank you, Alhamdulillah.
Alhamdulillah. Terima kasih dokter. Syukron.
There is a question in the chat box, okay? Assalamualaikum. I asked about it. How do guidelines for preoperative fasting and airway assessment in children differ between Malaysia and Indonesia, particularly in high-risk pediatric surgical population? What are the unique challenges and solutions in managing the airway during pediatric laparoscopic or thoracic where lung isolation may be required? Okay, let me answer the first question. Well, I'm not quite sure what sort of high-risk pediatric surgical population you're talking about, but I understand if they is it high complexity surgery or the patient is at risk of aspiration. But anyhow, I think when you look at pre-op fasting in Malaysia, I have to say our pre-op fasting we still allow clear fluid only up to 2 hours before op, where else solids is 6 hours and milk also 6 hours, cow milk 6 hours, breast milk depending on the age neonate and children. An infant is going to be, toddlers is going to be, infant is going to be 3 or 4 hours. So, but I know the European country, they have actually come up with guideline 1 hour clear fluid, and many countries like UK and recently Australia, they are also publishing their work. SIP, they call it SIP till call. Means you can drink clear fluid a certain amount. You have to be very precise how much, until operation call, because there are a lot of study out there that shows water get through your stomach very fast. About 20 minutes is gone. So when you call, the moment you call and getting the patient down to theater, even in a super efficient country, it takes about 20 minutes. And in my country, it takes average 30 to 40 minutes. So provided it's only clear fluid, okay? But still with that, we have tried to propose this, but the main college has not agreed to these changes yet. So I think I'm quite happy if it's just one clear fluid up to 1 hour at the moment, provided it's clear fluid. And in this era where ultrasound is available, yeah, if you have and you have any doubt, you could then ultrasound them. If you worry about the residual water or whatever. What are the unique challenges and solution in managing the airway during pediatric laparoscopic? I think pediatric laparoscopic is not an issue, as I've mentioned just now, because they use high intra-abdominal pressure due to the pediatric laparoscopic work. This is the sort of cases where I use cuff tube. And also thoracoscopic, I use cuff tube. Unless the baby is really small and to use a size 2 cuff tube, sometimes it's difficult to actually do suction and all that. Maybe we don't. And in this sort of patient, normally my surgeon said it's okay, just push one lung, So one lung isolation, what do we have here? We still, depending on the age, we use one lung, we just isolate one lung with bronchial blocker to a certain age. And we also have just push the tube to one lung and let the other one lung collapse depending this is we have to speak with our surgeons. And there are also where they are really difficult, we couldn't collapse it, then we do 2 lung ventilation, but small volume, high frequency ventilation. So depending on different age. Yeah, I think this is another topic altogether about lung isolation. I hope that's helped. I don't know. This is from Naim Ismail.
Okay, thank you, Prof. Ina. Maybe another question from the audience.
Assalamualaikum warahmatullahi wabarakatuh, Prof.
Waalaikumsalam.
I want to ask about from your experience, what are the common pitfalls and cured in pediatric airway case refer from rural on no specialist center, and how can this be minimized through cross-border train uh, programs?
Sorry, how common pitfall? What are the common pitfalls in area where there's no specialist?
Yes.
And
Uh, and how this minimize through cross-border train program. This
cross-border train program. I don't quite understand. What do you mean? Sorry, okay. Let me answer the first part first, and then I will need someone to I will need you to elaborate what you mean by cross-border train. Is this a program that you have in Indonesia? Okay. So in area where there's no specialist, it's not easy, it's tough. But as I told you, it's all about preparation, okay? You have to be it's like bawa kereta ya, kayak Formula One, right? It's all about to cut down your cockpit time from how many seconds to whatever second the shortest you have. It's all about practice. Practice makes perfect, right? And if you are in a center where there's no specialist, and in Malaysia it does happen, but not many. I think in Sabah, Sarawak, and the very rural part of Malaysia, this happen. You then have to understand, be able to diagnose that this is a difficult airway. And if you have time, right, you need to transfer the patient to the nearest hospital with specialists. Okay, because a patient who is still breathing, not in severe respiratory distress, you can give oxygen, aid them with oxygen, sit them up, then you need to get them to the nearest center with specialty, all right? Because if you're alone, sorry, am I still with you guys? Hello?
Yeah, it's clear, Professor.
Okay, because one phone call just came in and I lost the whole screen. Okay. My God, I can't see everyone. Okay. Okay. I can see now everyone. Right. So where was I? So so if you cannot, you don't have any skills at all, just put on a mask. All right, oxygen as high flow as you can, sit up the patient, get the next person who is available to receive this patient quickly. But if the patient is in dire straits, all right, kalau dibiarkan mati, dihantar juga nggak sempat, then it's very, very important for you to first tell this to the parents and get support from all your team members there, because you have to tell the parents, look, the risk is very high. You don't have the skill, but you need to do this. But bear in mind, you have practice. You've got the equipment. If you don't, I hope you have video endoscope, but if you don't have video endoscope, you know how to put you know how to insert an supraglottic airway device, because supraglottic airway device is one of the easiest device to insert in many occasion, and the risk to fail is very low. Except in my test, the one with 5 kilo to 6 kilo lah. But otherwise, the risk is to fail is very low, 0.86% only. Okay. So, and you can put laryngeal mask, ventilate, the patient won't die as long as you can oxygenate, and you can back mask ventilate until you can transfer to another center if you cannot railroad the supraglottic airway device with an ET tube. Okay. So, but if you have trained and you know how to put supraglottic airway device a second generation, and you can tube through it via an exchange technique with a fiber optic, then you can do it. All right. So it all bears down back to knowing plan A, plan B, plan C, plan D. Okay, kalau nggak percaya plan A, pergi ke plan B, tak percaya plan B, ke plan C. And kalau betul-betul patient ni kalau dihantar mati, nggak dihantar pun mati, then you have to tell the parents, kalau perlu saya perlu tebuk aja. Ya. And you have to document that before, because I don't know, we live in Malaysia where medical legal is on the increase. So I think I'm just telling you from my experience, you have to be able to tell the mother, okay, this is urgent. Kalau enggak dibikin apa-apa, mungkin boleh mati. So I need to do a hold. So you must learn. So where do you learn all this? Attend difficult airway workshop management. If you're going to be put into a place where you going to be alone, tell your boss, look boss, kamu mau kan saya kerja di sini sendirian, nggak ada specialist, so I need to be trained this much. Okay? But if you cannot, then I think you need to know, at least put the supraglottic airway device and send the patient out. If the patient is nearing to collapse. But if you can then put an oxygen, you can transfer the patient to another hospital. That's also an option. I don't know. That's my thoughts on this. Any idea from consultant di sana, Rudy, or Dr. Akbar? What would you advise?
Okay, thank you, Prof. I think the first important thing that we must prepare the pre-operative assessment to assess difficult intubation. I want to know about your experience, especially about ultrasonography to assess predicted difficult airway. If you do USG for assess size of ATT, diameter of ATT you can do in your baby, in your patient, before you do induction in your patient. Maybe do you have experience about USG?
I don't routinely do it because I don't know. I'm not a very ultrasound techie, but yeah, we're trained to do ultrasound airway. We actually once upon a time look at studies on looking at what size of LMA we want to use, using ultrasound. But I think a lot of it is very academical, looking using ultrasound to check for ETT size. Because at the end of the day, in a daily day-to-day routine, right? We just want to be quick. I just use the H as a gauge, and then I see this is what my MO also practice, my medical officer practice, they use the little finger to see the size. All right. Then we gauge the size of ETT that we want. But what I find it even is better to use ultrasound if in a patient where you anticipate difficult airway, where you want to look for the cricothyroid membrane, then and you think the risk of failed intubation is higher, then I think I feel it's more important to learn how to detect your cricothyroid membrane. And then you can put a tanda di situ. So if you need to do IFONA, at least you have sort of an idea where it's easy to pierce the trachea. Does that answer your question, Dr. Akbar?
Okay, thank you, Prof.
So what do you practice? Do you do it routinely, Dr. Akbar?
It was Dr. Inol.
Dr. Inul, oh sorry, Dr. Inul. Do you practice it routinely? No, I don't know who's speaking because, yeah. All right. I think
Yeah, Prof.
if any more question, yeah, because it's already 5:20.
I have a research about the predicted airway with WSG in, but not in all age of pediatric patient.
Yeah.
Okay.
Yeah. So yeah, it'd be good. If you have done it, you should write it up. And yeah. Did you publish that paper? And what's your experience? Would you like to share? I'm not an expert. I mean, I do use ultrasound, but I think because sometimes it's just a lot of things I can get away without using ultrasound. I don't use it as much. So what was your findings? Would you like to share?
Yeah, I think we can collaborate and discuss more about the USG for airway assessment before induction and before we know that how about the difficult airway in this baby. I think it is a challenging, Prof, but I know that we must have more data to have conclusion about this. Thank you, Prof.
Yeah, that'd be, I mean, uh, if there's like cystic hygroma, tumor like that, it's nice to know where your trachea is pushed to. So yeah, that will be a good way to ultrasound if you you're able to. Yep. Well,
Thank you,
and
Prof. Any question from our residents? Okay.
Thank you, Prof. It's an honor for me to attend your lecture in this afternoon. My name is Rahmat Dwi Saputra. I would like to ask about in pediatric children with heart intubation with massive mass, maybe in the
sorry, I can't hear you.
I'm sorry, Prof. Yes, I'm the technician. My name is Rahmat, and I would like to ask about in patient with massive mass in the neck, and it's hard to intubate. What's your strategy in this patient? The induction in awake condition or in sleep condition or apnea condition?
So it's difficult to answer if you do it just directly. There's a lot of things I need to know if there's other investigation that has been done, like X-ray, where is the trachea, how is the patient, is there an obstructive airway, how bad is the obstruction, if it's in the neck, it's very important during history for you to see how much obstruction it caused to the patient, what position improve it, you know, um, and how old is the patient? Is the patient cooperative? Uh, is it a new infant versus an 8 years old? All that is very important. Whether they are cooperative for, I don't think children are cooperative for awake, but they might be able to take sedation. And the sedation, if they are cooperative for sedation, one of the sedation that you can use and maintain sponge vent is by using dexmedetomidine infusion. They are asleep. They are not. They are sort of asleep. And you can give a little bit of either propofol. You maintain the spontaneous ventilation, and you can do fiber optic. But and then you can slowly look at where to maneuver into the vocal cord. However, what I want to say, but when there's a massive, I think most importantly when there's a mass on the neck, right? You need to know where is the best position, because whenever they turn something somewhere, the mass can collapse, can push the trachea. So if you can get an X-ray just to show that your trachea is pattern or not, what's the size first, you can know what's the airway opening, what's the size tube you can do. But let's say you cannot get access because it's an emergency, then I think the role of ultrasound is there. You can detect where is the with the, I'm just thinking in my brain, cystic hygroma lah, a huge cystic hygroma that push it away, you know, and then you can use ultrasound just to detect where is the trachea. And then if you think you, then the option is to, I don't think they can do awake, but you can do sedation, infusion dex, or gas deep gas inhalation technique, and I will laryngoscope with a video laryngoscope. Yeah.
Well, oh, yeah, okay, thank you.
And yeah, but I think with all these DEX infusion, it's very helpful, you know, DEX infusion with a bit of propofol, then you can get them to be quite cooperative if they're a bigger child, but if they are not, you just still can do DEX and propofol, spontaneous. At least when you are laryngoscoping, you won't lose the depth of the anesthesia because the propofol and DEX is still working. So the chance of going light is much lesser than using sevoflurane lah to get the airway by maintaining spontaneous ventilation. In this sort of patient, I will be worried to paralyze because I'm worried that whatever the tone that is holding the airway will collapse. And when you paralyze, you will collapse the muscle tone, right? And this will collapse the airway. Then you might lose the airway altogether.
Yes, I also think about that because when we induction the children with massive mass in the neck, I just aware when we give maybe muscle relaxant and we can take the airway and give the ventilation, it become obstruction and we can give the treatment to the patient. And I just thinking about the best strategy to how to intubate this patient because at the past we pernah ya dapat satu pasien seperti ini. And what if the intratracheal local anesthesia, Prof? Is there any consideration for this patient?
Intratracheal, you mean percutaneous?
Percutaneous.
Oh, I don't do this. I don't like invasive thing. So
Oh,
I don't
okay.
do that. Because if is the patient awake or asleep?
Awake.
Oh no, I
But
think it.
but the age of the children is more than 10 years. So
Oh,
it's it's sedikit challenging to mengajak dia kooperatif.
oh, I think in that, right, procedural sedation is important. I mean, Dex IV. Do you have dexmedetomidine?
Yes, we have dexmedetomidine.
Dexmedetomidine, then a little bit propofol, or some people use propofol ketamine so that you don't overdose on the propofol, you know. That helps to sedate them. And then when I can gently laryngoscope them, I then I just squirt with an atomizer or just granular. I spread the vocal cord with LA. Yeah, just like you do bronchoscopy, stuff like that. I am very, I don't like to do puncture children unnecessarily. And I don't know, if they are already uncooperative, you know, how can you inject them and hope them locally, they are not they are anesthetized locally, but you expect them to tolerate your intubation? I don't think it works. You must then sedate them at some point. But the good thing, you know, children, you know, that's why the history of which part, when you tidur malam, kat mana tidur malam? Tidur malamnya mengereng, terbalik, ataupun terlentang, yang mana. So when you have difficulty in mask back ventilation, you then need to turn patient to that way. It's like anterior medial sinus mass sort of thing, you know, like you have to lift because all that will collapse, right? And you need now to open up. So you know which position the patient will be able to open their airway. So history taking in this sort of situation is very important. and then telling your group, okay, this patient tidurnya kayak gini akan ada problem, tapi kalau dia tidur kayak gini nggak dia bisa bernafas. Jadi bila I don't paralyze lah, but if they're deep enough, sometimes you gas induce too deep, then you get obstruction, right? Then I know that, okay, let's turn the patient to the area where he breathe the best. Then turn, because budak kecil nggak terlalu besar kan, selalunya beramai-ramai kita boleh turn, and then yeah, then you intubate in that position lah.
Oh, siap, siap, Prof. Berarti kita intubasi budak kecil itu posisi itu miring berarti.
Tergantung di mana keadaan apa yang relieve the block.
Oh, oke.
I haven't said that. I haven't done that in many occasions, but I've had that in one patient who wanted, they just wanted to do MRI to get a biopsy, and I thought, oh my God, oh, no, yeah, CT scan or MRI. I just wanted a biopsy. I think it's a CT scan, and I thought, oh my God, just a 15 minutes procedure. I'm not going to struggle so much, you know. So, but I need to know if I give this sedation and he stopped breathing, I need to know how I'm going to relieve it. So I asked him how he sleep, then whatever. But I managed to do it just with sedation. A lot of things, just if it's just for biopsy stuff that we do with sedation, and they can get away with that. Then you don't need to worry about intubating. But you always have to have plan B. Kalau tiba-tiba sedationnya terlalu dalam, kalau dia berhenti bernafas, apa yang perlu dilakukan? Kita nggak perlu risau kerana kita sudah ada plan B. Apa kita mau buat?
Baik, terima kasih, Prof.
Okay. All right. Do you think I can stop? This is until, because I really need to, I have a dinner tonight. And it's our 50th anniversary of transplant in Malaysia, and I'm invited to be one of the guests there. I think the session is supposed to be 1 hour, right, Rudy? Or 90 minutes? Yeah, so I think one last question. Any question? Tadi Alfan ada angkat tangan ya? Ya, saya lihat. Ya, Alfan, apa yang bisa dibantu?
Oh, thank you, Prof. My name is Benny Firmansyah.
Oh, Benny,
Maybe
bukan
one
Alfan.
from me. I want to ask you about your strategy. If we found or against the case with pediatric difficult airway, how about your strategy to do extubation? It must be with light sedation or awake extubation or deep extubation, or there is any recommendation from you, Prof?
This is already known difficult airway,
Yes, already difficult airway.
and it's difficult airway due to a tumor or just very anterior and operation done, all that at the end of a surgery, or what? I must know.
Yes, Prof.
Okay, because it
Random.
has to be patient context. Okay, I cannot answer if because I've done it in several ways. Actually, Difficult Airway Society has a good extubation strategies. I would recommend you to go back and read it, but I would look into the cause of the difficult airway. All right, if it was a very anterior, like the child that I shared just now, Adi, who went for palatoplasty, pair of mine, right? It's palatoplasty, you cannot make them cry, then they cry, they will need. So I will ensure that patient has good pain relief. But I would still want them to be fully awake, all right, so that they can protect their airway. So I will I will extubate awake for this sort of cases. But if you are worried because there is some tumor near the vocal cord, or a very small diameter due to some tumor, some growth pressing it, and you're going to extubate the patient, you could leave a frova in like Cook's airway, a small size, which you can ventilate, which you can insufflate oxygen. You railroad to the tube, leave it there, All right. And then you can extubate. Just leave it there. So if in case the patient desaturate at any point and you need to intubate first, you can give oxygen through there. And then you already have a marker of that. But you really need to tape it properly lah, so that you can railroad your tube and laryngoscope and railroad it back. But I always extubate them most of the time. Most of my difficult airway, I will ensure they are awake. But if you're worried they're gonna cry, you need to think of a way how to blunt all this crying lah, and bleeding.
Okay, thank you, Prof. Okay. Is there maybe any you added some drug like lidocaine or something else maybe, Prof?
Lidocaine, not at extubation, because I don't want their vocal cord to be You mean lidocaine IV or lidocaine at the vocal cord?
IV, Prof.
Oh yeah, I do give IV lidocaine. That is 1 milligram per kilo for obtundation. But I don't practice this routinely, but I've got a colleague from another center, from another country, another center, who give dexmedetomidine. Just half 0.5 mic, 10 minutes infusion, so that because Dex doesn't, she gave it for her cleft palate, because she said she doesn't want her kids to cry, but they are awake because Dex doesn't cause it doesn't, the patient are still a little bit sedated, but no respiratory depression and can understand command. So she will off everything, she'll give dexmedetomidine and extubate. But in my center, even in the difficult airway with palatoplasty, our surgeons are pretty good. They said if patient shouldn't bleed if they cry. If they bleed, if they cry, means the hemostasis is not good. So I like my surgeon. So I will ensure I'll give multimodal analgesia and all that. And they will put local anesthetic, and I still extubate them awake so that they can protect the airway. I mean, that's my practice lah.
Thank you, Prof.
Okay. All right.
I think maybe that's enough, Prof. Thank you, Prof. Ina, for all wonderful for your wonderful lecture and discussion. I think we all gain many insight and new perspective on managing pediatric airway, such from identifying the possibilities of difficult airway and then several strategies to tackle different difficult airway conditions such as LMA using video laryngoscope or flexible bronchoscope to even Ivona condition. Thank you, Prof. Once again. Maybe I will give the screen back to Arfan. Thank you.
Thank you.
Thank
Thank
you.
you.
We can meet again the forum from this to this research after this forum in the next days.
All right.
Okay, Prof. Stay healthy.
Thank you so much. You guys take care too. Have a good weekend. And until the next series of lecture, I hope that has been beneficial. If ada kesalahan dari pihak saya, minta maaf. And I hope that is going to be fruitful to all of you. Thank you so much.
You, Prof.
Okay.
Thank you,
Assalamualaikum. Have a good weekend.
Okay, thank you for everybody, Dr. Akbar, Dr. Rudy, Dr. Rudiono. We hope that today's guest lecture has given us valuable insight into the purpose of achieving excellence in pediatric anesthesia and improving patient care. Thank you once again to our teachers, staff member, and all of you for your contribution in making today such a rewarding experience. We look forward to seeing you again and have a great time ahead. Wassalamualaikum warahmatullahi wabarakatuh.
Warahmatullahi wabarakatuh.